So I'll move straight on to expert guidance on particular topics. Thank you.
Shobha. It's really my pleasure to be part of the Visual Academy Steering Committee. And we're going to move on to, please note our financial disclosures. So I'm just moving on to the initial slides here. Here we are. So the first topic is expert guidance for the use of new regimens with extended injection visit interval. This is really important given the second generation of longer acting therapies. And remember, this is drug agnostic, whichever therapy that we're talking about. So it's very clear that the first generations were very good at improving visual acuity, but often required monthly or bi-monthly treatment. And obviously, the recent researchers try to extend these intervals with second generation medications. So just to give an outline of the Visual Academy publication, the objective was to provide guidance on how best to manage these regular and more extended intervals. And it was done really through a participant survey asking how comfortable physicians were to extend. And the preliminary opinion was that extended retreatment intervals are suitable for patients who respond well in particular. And of course, surveillance is required. Let's just dive into that a little bit deeper. So the methodology included the expert opinions and advice from the Vision Academy Steering Committee members. And really they were asked three things. What was the longest injection interval comfortable? How frequently would you want to monitor in between, if at all? And if it reactivated the disease, what would be the reduction? And these preliminary recommendations were presented through a live meeting in 2025. So base case scenario for diabetic macular edema I'm presenting here is that this is the only affected eye that was mentioned or being treated. And the longest comfortable retreatment interval was around 16 to 24 weeks, often driven by the data, but practicality of monitoring the second eye. And the frequency of surveillance, if required, was around 12 to 16 weeks. And again, this was driven because of retinal non-perfusion or retinopathy grade status, never forgetting that we need to monitor this at the same time. And a reduction in retreatment intervals should be between 2 and 4 weeks if there was reactivation. So let's have a little look at the situation for neovascular AMD. And the base case scenario was treating the only effective eye. And very similar results here. So the longest comfortable retreatment interval that most physicians recommend was between 16 and 24 weeks. But frequent surveillance between 12 and 16 weeks was recommended, particularly for reactivation in those difficult treat ones, but also to monitor the other eye in case that developed neovascular AMD. And this was the case across all macular neovascularization subtypes. With growing experience, perhaps longer treatment intervals could be extended further. So in summary, this publication provided background with the Vision Academy expert opinion on the consensus recommendation. And until longer-term real-world evidence becomes available, the Vision Academy Committee practical recommendations will be informed by these expert opinions. So I'm going to move on, if I may, Shobha, to the second Academy recommendation of the development of a new concept called time in range standardization of a measurement of clinical endpoints in retinal diseases. Now let me explain that a little bit more. So that in clinical trials and clinical practice, we tend to focus on the absolute visual acuity as an endpoint, perhaps non-inferiority, to enable cost-effective and efficacy outcomes to be demonstrated. But it doesn't take account of those fluctuations in between. So this new concept of the time in range may well be important, and that is something that is already used in other areas such as diabetology. So let me explain that a little bit more. So perhaps if we talk best corrected visual acuity, instead of using that final endpoint, we looked at the curve over time of what happened of visual acuity. Now, this is not an entirely new concept. Statistically, we can use area under the curve analyses, which do look at effectively over time what is happening with the visual acuity. But there are some disadvantages of that, and time itself may be a better outcome. And this slide demonstrates it really nicely. So look on the left-hand side here, we have the visual acuity going up and down in green, where it's more of a flattened curve on the right-hand side. Both scenarios have the same visual acuity starting and finishing point. Both have a similar area under curve, but the one on the right-hand side has more time in range, and perhaps this is more meaningful for our patients having visual acuity. And of course, this are perhaps not just an important concept in retinal diseases, but could be applied and has been applied to other therapeutic areas, such as the phasing of intraocular pressure over time in glaucoma, and perhaps in uveitic conditions where the control of inflammation can be plotted. So what are the Visual Academy recommendations? Well, first of all, we need to understand the limitations of reporting a single one-time endpoint. We need to consider whether not just best corrected visual acuity time in range is important, but perhaps there are other parameters which are important, such as central retinal thickness or even quality of life outcomes. So in summary, this could be crucial information in both clinical trial primary outcomes, but also clinical outcomes as well. And we may want to consider this not just for best corrected visual acuity, but also for other important outcomes as well. I'd like to thank you for your attention.